Data lab, what's the data lab? It's a kind of phrase that we use here at the Nuffield. We have quite a strong element of quantitative analysis with an emphasis particularly on making the most of existing information sources within the health service and in healthcare generally. And the data lab is really about pulling those information sources together in ways that informs policy, research, evaluation and service delivery. And there's been some debate about whether or not the reforms are revolution or evolution. It's interesting to see that David Cameron suggested the reforms themselves are evolution, but in terms of information, we're quite comfortable using the word revolution. The idea that what's happening in terms of information within the health service is really potentially quite huge, and big things are happening and are quite important in the way that the system develops. And having had 20 years experience with health service information, my sense is over the past year, the prominence that's being given to the needs of the information systems is greater than it has been before. I should just also mention one of the joys of Googling is whilst I was looking for that quote in the HSJ, I stumbled across this particular article by some young whippersnappers, Jennifer Dixon and Nick Mays. The white paper spells evolution, not revolution. That was New Labour, New NHS in 1997. For me, one of the encouraging signs about the white paper is, and also one of the challenging signs, is the importance of information to some of the reforms. This is just an example. This is the quality improvement system. And the way that information on improvements in our information systems are needed to maintain these types of structures. And I think it's going to be particularly challenging over the next few years, particularly as we go through periods of structural change, to ensure that the data we have and the way that we use it can really fulfill some of the goals that are laid out in this table. The issues that I wanted to mention are, firstly, a couple of the things that the Secretary of State talked about earlier, some of the important changes that are highlighted, the issue of outcome measurement, the challenges of how we do outcome measurement. I've been in this business so long that I really have got a PhD in outcome measurement. About 15 years ago, I had a job as an outcomes project manager, East Anglia Regional Health Authority. So there's a sense that the outcomes agenda has been moving very slowly. Let's face it, the work we did in East Anglia hasn't brought about any great revolutionary change. And there's a reason it's gone slowly. It's not easy to crack. And I think some of the questions that were raised about how you balance proper outcome measurement with some intermediate markers is really important, an agenda that we have to work through. Similarly, the information for patients and users of the service as well. It creates demands for new ways of shifting information that I think will be quite challenging, but also quite important. The three areas that I did want to pick up in our coming sessions are some examples about how information can help with the agenda on efficiencies, some of the questions around how information can span organisational boundaries, and then finally the issue of allocating resources in the new world. Underlying all those is kind of use of information at the person, at the individual level. And this strange little diagram that we call a theogram, after one of our analysts called Theo, is something that we use a lot. And it's very simple. This is one person over a 2-year period. The little crosses on the bottom are all about their GP activity, when they went to see GPs. It's going from left to right. The little triangles are when they went to hospital, A&E, emergency. That white, pinkish stripe across the top is social care input. What this little diagram shows is just the idea of pulling together the events that happen to one person as they collide with health and social care systems. And this picture, I think, is very important to lots of the ways that we need to use information and lots of the ways that information needs to be used in relation to the white paper. The work on outcomes is about changes in health status. It's this type of information that can show us those changes over time. Of course, to create these pictures, well, first of all, I should say, we're not the only ones doing these, and there's some really encouraging signs around the health service about the way places like Torbay or Redbridge are actually organising their information to show these pathways themselves. This is just an example of what we had to do to construct those pathways for one PCT and the scale of information involved. Now, for the younger people in the audience, I see you're quite a young audience, those square things are called floppy disks. Do you remember them? They weren't very floppy either. They weren't very reliable. In days of yore, they were measurements of information storage and size. All those blue things represent the records that come from the GP practices in this one PCT. The 48 million records that come from those GP practices. The top ones at the top line includes the A&E records, the outpatient records, inpatient records, social care, and a very tiny little disc for community matrons. So we were able to put together this type of information. Very often, information analysts in the health service are quite smug because they can deal with the inpatient stuff, and yet there's this huge mass of intelligence in relation to general practice that we are really finding difficult to tap into. And in terms of the future agenda, I think the ways that we can use that safely and securely is going to be a critical issue. One of the things that happen when you start looking at this information is you see some of the detail. This is an example as well. It's a bit like the theogram, but in this case it's within hospital, but this is looking at the cost profile. It's taken from a hospital with a patient-level accounting system, PLIX information system, which enables you to look at the costs of, in this case, one person over a year. And that person had a not very good year. The size of the circles is proportionate to the amount of spend in the hospital, and we see they had 2 significant and costly inpatient episodes and a whole lot of satellite activity as well. So the issue here is just to point out that this is a relatively costly and complex patient, that standing back from the individual episodic payments, you get a different perspective on what their annual costs are, but also to recognise that it's an example of the variability in patient costs and patient needs that the new system will have to account for. According to our analysis, the most expensive 3% of patients in this hospital we looked at accounted for something like half the total patient costs. So there's a very uneven distribution of costs. And one of the issues in any system, but particularly in the new system we're going for, is how resource allocation is going to account for some of that variability. This wonderful slide shows, if you like, an example of the different coloured people representing their different needs and the different cost implications. What we're looking for in the future is to say, how do we allocate resources to a general practice population based on that profile of needs in the population? Up to now, we've tended to do it on an area basis, with GP lists being the basic unit. We're not restricted to areas. So we need technologies that can do that type of process. Of course, the health service costs are only just one part of the equation, and for many patients, particularly those with long-term conditions, there are significant costs associated with social care. In fact, my costly inpatient at £37,000 isn't that much more than a year's worth of nursing home or residential care home, the costs of those situations. And there are clearly overlaps between healthcare and social care in ways that I think very often we don't understand. A piece of work that we did this year and published was looking at the last 12 months of life and actually pulling together information about the hospital use and social care use of people in the last 12 months of life. And we got this fascinating picture, which I hope you can see, that as age increases, not surprisingly, people's social care costs go up. That's no great shakes. We kind of know that, I suppose. But the way that the hospital costs of those people fall. So in the last 12 months of life, people who are 80, 90 plus had significantly lower hospital costs than people 50, 60, 70. And one of the things that's lying behind this is the way that different patterns of hospital use are associated with different patterns of social care use. There's been some discussion this morning about some of the ideas behind this. A rather wonderful quote from David Nicholson. Realising that savings needed to invest in improving outcomes means moving from a system configured to diagnose and treat to one configured to predict and prevent. Those predict and prevent words are lovely to us at Nuffield, and you'll see a little tract in your thing about modelling and cost prediction, all that kind of stuff. What lies behind this is is a huge agenda and something that we've been working on for a long time. We recognise the needs to tackle the rising patterns of emergency admissions, to perhaps reduce reliance on acute care and think of alternatives. But realistically, over the past 5-10 years, the track record has not been fantastic. One of the markers we can use are things called ambulatory care-sensitive admissions. These are conditions where admission to hospital is potentially avoidable or preventable. There'll always be some level of ACS admissions, as they're called, but the overall level is indicative of how well we're preventing those emergency admissions to hospital. And if we look at trends in these ACS conditions, what do we see? We actually see some successes. This is a pattern from 2001 to about 2010. Some good news. Not very often I give them good news, I tell you. Angina. Look at the emergency admissions for angina. In line with international trends, it's been falling quite consistently. Similarly, good news on congestive heart failure. Perhaps not quite as good, but actually we're seeing a pattern there. Something is happening in terms of the clinical care, in terms of the way the system is dealing with these people, which is really quite interesting. Of course, you know what's going to happen now, don't you? That's pneumonia, which is actually increasing during this time. And this one is urinary tract infections and pyelonephritis. What's happening with these very short stay elderly complex patients, we don't really know, but what we do observe is net huge increases in emergency admissions for those that are actually swamping some of the good things that we're seeing. And of course, the solutions to managing care outside the hospital to avoid these, we're not short of ideas, we're not short of ways of looking at these, but sometimes the evidence about these solutions can be limited. In your packs, you'll see there's a report that we're about to publish. It's not public yet. It's being published next week. But it's an evaluation of 8 different interventions, community-based interventions, where part of their rationale was about trying to reduce hospital utilisation. These were part of the Partnerships for Older People projects. There are many projects under that POP banner. We were actually asked to look at 8. And of those 8, what we did, we tracked through the individuals who got the intervention, so 500,000, quite big numbers in each study. And we created a match control group that were as similar as possible and then looked at the changes in those. And the overall impact, what we should be seeing is a reduction in utilisation in our intervention group compared to our control group. In fact, what we're seeing is, if anything, was a slight increase in utilisation in the intervention group. So certainly not the types of reduction that we were hoping for from some of these interventions. So it's an area that's important in terms of developing our evaluation skills that match what we want. Finally, just to mention that at the moment, one of the areas where people are particularly optimistic about changing the balance between hospital care and other care, particularly around long-term conditions, is in technologies, these assistive technologies, things like telecare and telehealth. And there is, if you don't know, a huge trial, the most complex trial I've ever come across, a randomized controlled trial called WSD, the Whole Systems Demonstrator, which has been going on for about 2 or 3 years. We are part of that trial. We're looking at the impact of telehealth and telecare on utilisation of health and social care services. Really big, I mean, and hats off to the people in the department who funded a trial that's as ambitious as this. One of the problems is that up and down the country, people are already investing in some of this technology about telecare, while the results of the trial won't be out for about 2 or 3 months. We're right on the edge of getting the results, but still, up and down the country, telehealth is emerging as a potential solution. You'll have noticed the Beatles. You did notice the Beatles references, didn't you? Yeah, please, somebody. The Beatles, Lennon and McCartney's interpretation of the revolution ended with, "Don't you know it's going to be all right?" So that's the question for you. Is it going to be all right?